Next topic we're going to do is non-cystic fibrosis bronchiectasis, one of my favorite topics, top 10 articles. And without further ado, we're going to look at natural history, airway clearance, macrolides, inhaled antibiotics, DPP1 inhibition, and then a little bit of NTM. First trial you should know is the Pasteur Embark Natural History Etiology of Non-Cystic Fibrosis Bronchiectasis, Pasteur Thorax 2000. Embark European Respiratory Journal. We're looking at a 28-country registry, and Embark of greater than 16,000. The big takeaway is that what we call idiopathic bronchiectasis, you could find the cause in 47%, whether it's immunodeficiency, ABPA, ciliary disorder. The annual exacerbation rate is 1.85 per year, and about 40% of this Pseudomonas colonization in these cases. BSI score predicts mortality and hospitalization better than etiology. We're going to take a look at that. For every patient, you should do high-res CT, spirometry, play the game of bronchiectasis, IgG, AM, and E, ABPA screen, Aspergillus specific, IgE, sweat test if you're young or early onset, and a primary ciliary disorder screen, which is nasal nitric oxide, autoimmune panel, NTM sputum cultures, Embark 2024, the disease severity, not the etiology, predicts prognosis. We'll look at you should calculate the bronchiectasis severity index. So the takeaway of this message is that 47% have a treatable cause. Number 2, ERS 2024 guidelines. This is the operational Bible, basically. Daily airway clearance is a strong recommendation. Hypertonic saline, conditional long-term macrolides, strong for greater than 3 exacerbations. Remember, even if you have Pseudomonas colonization, you could use long-term macrolides, but not monotherapy when you have NTM. Inhaled antibiotics are conditional, no routine ICS, and pulmonary rehab is conditional. We'll take a look at that article. But ERS 2024, basically airway clearance, macrolides, inhaled antibiotics for Pseudomonas, and no routine inhaled corticosteroids. So then we have the BLESS and BAT trials, which are the trials that we look at long-term macrolides. And BLESS trial showed a 43% reduction. The BAT trial, which was azithromycin, 500 milligrams 3 times a week, showed a 62% reduction, huge in exacerbations. BLESS trial looked at erythromycin. You have to get a QTC and NTM check before you start the macrolide monotherapy, because it could cause macrolide resistance. 3 negative monthly sputum cultures for NTM required before starting. Again, you want to screen NTM and get a baseline EKG, but macrolides, the BLESS and BAT trial, this is back in 2012, 2013, showed a reduction in exacerbations with macrolide monotherapy. So inhaled antibiotics modestly reduced exacerbations in Pseudomonas. So we look at the ORBIT and the 2 Respire trials. So the ORBIT trials, liposomal Cipro, showed a rate ratio of 0.78, so it decreased exacerbations by 22%. Respire 1 showed the same type of thing. Respire 2, p-value was not significant, but essentially we say a 20% exacerbation reduction in the meta-analysis in Pseudomonas colonized patients. You should know the ORBIT 2019 Lancet Respiratory Medicine, Respire 1 and 2, Lancet 2018. So if you have a patient with Pseudomonas plus or minus plus about 3 exacerbations, that's the patient who you'd want to use. You want to optimize airway clearance, macrolides, then you would add an inhaled, let's say, tobramycin every other month. And you could use Cipro DPI as well. Inhaled antibiotics modestly reduce exacerbations in Pseudomonas, non-cystic fibrosis bronchiectasis, reserved for Pseudomonas, plus greater than or equal to 3 exacerbations on optimized therapy. It's not a first line. So what about the osmotic agents? Nicholson, Blue Journal 2012, and POSA, Blue Journal 2021. we're looking at mechanisms where you rehydrate the dehydrated airway surface. So we're looking at 7% hypertonic saline, which is the most studied, significantly improved the sputum weight, mucociliary clearance, and quality of life, decreased exacerbations by 14% in the mannitol trial. That's the POSA mannitol trial. Only 144 patients, but it is approved in Europe. Bronchitol. So hyperosmotic agents draw water into the airway lumen, rehydrates the periciliary liquid layer, and improves mucociliary clearance. So you do want to start with albuterol nebulizer, then you do some physiotherapy, then you give the hypertonic saline. You could start out with 3%, make sure you titrate that, and you tolerate that, then you go to 7%. You could check FEV1 before and after the first dose to make sure that you're not causing significant bronchospasm. But basically, hypertonic saline shown by Nicholson Blue Journal that it improved quality of life, and you want to pre-bronchodilate to prevent bronchospasm. And know that there is mannitol, bronchitol, that also showed decreased exacerbations. What about airway clearance techniques? So active cycle breathing. I like to think about active cycle of breathing. You could think of it as a mnemonic, airway clearance, and big breaths, big breaths, and 3 huffs. So you basically take a very deep breath in, and then hold it for a couple seconds, and then breathe out. And that's huffing, and you're not coughing, you're trying to huff. So the large volume huffs, meaning large volume huffs, are for central airway mucus plugs, and the low volume huffs would be for distal airway mucus. And anyway, oscillating PEP, autogenic drainage, conventional chest PT. Oscillating PEP is stuff like Aflovest. The Murray had a 34-patient randomized control trial, but the Cochrane database looked at 15 randomized control trials, and active cycled breathing, decreased sputum volume, increased quality of life, decreased exacerbations. The pulmonary rehab is where you add real benefit versus usual care. 1 second. And then, so basically, it showed decreased exacerbations. It's non-negotiable. So daily airway clearance, strongest ERS 2024 recommendation. No one method is superior, and you should add exercise training. So then paper number 7 and paper number 8 basically is DPP1 inhibition. This is the Willow trial, which is the phase 2 proof of concept. Basically, cathepsin C activates in the bone marrow. It decreases the neutrophil serine protease is activated if you inhibit the cathepsin C, and that would be neutrophil elastase, proteinase 3, cathepsin G. If these things are let out by the neutrophil, then that will cause airway structural damage. And so what you want to do is inhibit the cathepsin C. Hazard ratio is 0.58, 40% decreased exacerbations. This set up the phase 3 Aspen trial. The sputum neutrophil elastase was significantly reduced. So just think of those 3 different things: neutrophil elastase, proteinase 3, cathepsin G, as breaking the airway structure. Then came the Aspen as the first FDA-approved therapy for non-cystic fibrosis, bronchiectasis, approved in August 2025. Brensocatib, 10 and 25 milligram doses. The rate ratio exacerbations decreased. Exacerbation free at 52 weeks, 48.5% versus 40%. There was an FEV1 decline. The 25 milligram was showed negative 24 versus negative 50. So, you lose about 50 cc's per year with bronchiectasis, and it halved it if you use 25 milligrams of brensocatib. Hyperkeratosis was the main adverse event. So just remember, decreased exacerbations by 21%. So the Bronchus and the Convert trial, this is paper number 9. So Griffith in the American Journal of Respiratory Critical Care Medicine, and Daly in the Blue Journal as well in 2019. So now we're looking at ARIKAYCE, basically, which is amikacin liposomal inhalation suspension. And this is for patients with NTM that still are having NTM despite having on triple therapy, which is azithromycin, rifampin, and ethambutol. So culture conversion at 6 months was 29% versus 9% with placebo. The Convert trial in 2019 was basically confirmatory, 29% versus about 9.7%. So again, the azithromycin, rifampin, and ethambutol is the first-line treatment, and then ALIS for refractory. Then you treat to 12 months after you have 3 consecutive negative monthly sputum cultures. Macrolide resistant MAC is a very poor prognosis. You should never start macrolides for NCFBE without first confirming 3 negative NTM sputum cultures. Double check that because I thought it's only 1, but I looked it up and it said 3. So I guess there's a difference of opinion there. Open evidence, I believe, said only 1. NTM MAC screen is mandatory before macrolides. ALIS, remember, 29% versus 9%. Treat 12 months post-conversion. Understand what it means to be converted. Paper number 10, Murray, AJRCCM 2011, ERS 2024. How do you treat an exacerbation? So if you have Pseudomonas colonization in a cystic fibrosis patient, you're going to be giving 2 IV drugs for like 14 days. But in a non-cystic fibrosis bronchiectasis, monotherapy is standard. You can use oral Cipro, which is better than actually Levaquin 750 BID for mild exacerbations. Sputum culture before you start. Non-Pseudomonas, you could use Augmentin, Doxy, and again, no steroids for exacerbations. Do not apply COPD exacerbation protocols to NCFBE. And remember, 2-agent Pseudomonas regimens are CF practice and not NCFBE. Sputum culture first, 14 days, oral when possible. Pseudomonas IV monotherapy, not 2 agents, but you could use oral Cipro for the mild exacerbations. No steroids, no ICS. The other ones to know is Bronchiectasis Severity Index, McDonald 2016. It stratifies you in the mild category, moderate, and severe, and gives you prognosis there. Clear, we went over that. Pulmonary rehab showing 300 patients, increased quality of life, decreased exacerbations. You should know the NTM guidelines in 2020. They looked at the Bronchus and Convert trials that we went over. And then knowing the pipeline, roflumilast is one of them, DPP1. There's a medicine called verucatinib, which is basically like brensocatib. There's a medicine that's coming out, itepekimab, which is an IL-33 inhibitor. That's an alarmin, sort of like Tespire. And then there's like ensifentrine that's coming out. So these are the major 10 trials with NCFBE, Pasture and Embark, 47%, idiopathic have treatable cause, ERS 2024 guidelines. You should know Bless and Bat 2012, Orbit and Respire 2018, 2019, hypertonic saline 2012 and 2021, that mannitol study. Murray and Clear, you should know a little bit about active cycle techniques, active breathing cycle technique. Remember, big breaths and 3 huffs. Willow trial and Aspen trial are really basically the same DPP1 inhibition, Bronchus 1 and Convert, knowing a little bit about NTM and then exacerbation management. Okay, thank you for listening.